Radiation protection. As professionals, radiologic technologists have the important responsibility to protect their patients, themselves, and fellow workers from unnecessary radiation. A complete understanding of radiation protection is essential for every technologist, but a comprehensive review is beyond the scope of this anatomy and positioning text. The basic principles and applied aspects of radiation protection, as described in this part, should be an essential component of a course in radiographic positioning. Every technologist has the obligation always to ensure that the radiation dose to both the patient and other healthcare professionals is kept as low as reasonably achievable, LARA. To protect patients and staff, the amount of radiation that is present or was received must be measured. A variety of radiation quantities, including exposure, air kerma, absorbed dose, equivalent dose, and effective dose, have been developed for this purpose. Exposure measures the amount of ionization created in air by X-rays, which is expressed in units of the Röntgen, R, or Coulomb per kilogram. X-ray tube output, patient entrance exposure, and scattered radiation levels are usually indicated by measurements of exposure. Air kerma, which indicates the amount of energy transferred to a mass of air by the photons, has replaced exposure as the preferred quantity for these applications. The unit of measurement for air kerma is the gray or rad. On average, the formation of each ion pair requires a certain amount of energy. In diagnostic radiology, an exposure of 1 R equals an air kerma of 8.76 milligray, mgy. The gray, rad, is also a unit for absorbed dose, which is the amount of energy deposited per unit mass by the interactions of ionizing radiation with tissue. For the same absorbed dose, some types of radiation cause more damage than others. Equivalent dose quantifies the risk for adverse effect for different types of radiation using the same relative scale. The product of the absorbed dose and the radiation weighting factor yields the equivalent dose expressed in the unit of sievert, or rem. The radiation weighting factor depends on the type and energy of the radiation. Commonly chosen values for this factor include 1 for beta particles, gamma rays, and X-rays, 5 for thermal neutrons, 20 for fast neutrons, and 20 for alpha particles. For X radiation to a small mass of tissue, the three radiation quantities of air kerma, absorbed dose, and equivalent dose are considered numerically equal, although they have very different conceptual meanings. Radiologic examination is directed at certain anatomy and results in a non-uniform organ dose. Effective dose indicates the risk from a partial body exposure by modifying the absorbed dose by various factors, depending on the type of radiation and tissue irradiated. Absorbed dose is used primarily for patient dose, and equivalent dose is used for radiation protection purposes, such as reporting the results from personnel monitoring. Effective dose allows comparisons of the relative risk from various imaging procedures. Traditional versus SI units. The SI system has been the international standard for units of radiation measurement since 1958. However, just as the United States has been slow to convert to the metric system for other applications, traditional units of radiation measurement such as the Röntgen, RAD, and REM are still in common use in the United States. Dose limits and patient doses in this section are designated in both SI and traditional units. 1 gray equals 100 rads and 1 rad equals 10 milligray, mgy. The gray is an extremely large unit for most dose considerations in medicine. A smaller unit of milligray is often used, 1000 milligray equals 1 gray. Dose limits. Radiation in high doses has been demonstrated to be harmful. Therefore, dose limits have been established by governing bodies to reduce the risk of adverse effects. The rationale for the dose limits is to make risk from occupational exposure comparable to the risks for workers in other safe industries, excluding mining and agriculture. The annual dose limit for occupationally exposed workers is 50 msv, 5 rem, whole body effective dose equivalent. Higher annual dose limits are applied for partial body exposure, 150 msv, 15,000 mrem, for the lens of the eye and 500 msv, 50,000 mg, for the skin, hands, and feet. Medical radiation received as a patient and background radiation are not included in these occupational dose limits. The annual dose limit for the general public is 1 msv, 100 mg, for frequent exposure and 5 msv, 500 mg, for infrequent exposure. For practical purposes, the shielding design for X-ray facilities is based on the lower limit. In essence, the facility must demonstrate that X-ray operation is unlikely to deliver a dose greater than 1 msv to any member of the public over the period of 1 year. The recommended cumulative lifetime dose for the occupationally exposed worker is 10 msv, 1 rem, times the age in years. 4. Example, a 50-year-old technologist has a recommended accumulated dose of no more than 500 msv, 50 rem. However, the principle of ALARA should be practiced so that the occupational dose is accrued at a rate that is very much less than the dose limit of 50 msv, 5 rem, per year. Individuals younger than 18 years of age should not be employed in situations in which they are occupationally exposed. The dose limit for minors is the same as that for the general public, 1 msv, 0.1 rem, per year. Personnel monitoring. Personnel monitoring refers to the measurement of the amount of radiation dose received by occupationally exposed individuals. The monitor offers no protection but simply provides an indication of radiation dose received by the wearer of the monitoring device. On a periodic basis, monthly or quarterly, the personnel monitor, film badge, thermoluminescent dosimeter, TLD, or optically stimulated luminescence dosimeter, OSL, is exchanged for a new one. A commercial personnel dosimetry company processes the dosimeter, and the radiation dose for the period is determined. Measurement of occupational dose is an essential aspect of radiation safety as a means to ensure that workers do not exceed the dose limit and to assess that the dose received is reasonable for the work activities. Each worker who is likely to receive 10% of the dose limit must be issued a personnel monitor. Generally, healthcare professionals, including emergency department and operating room nursing personnel, who are occasionally present when mobile X-ray equipment is in operation, do not require personnel monitoring devices. The radiation dose received by nursing personnel is very low if proper radiation protection practices are followed. Clerical and support staff working in the vicinity of the X-ray room need not and should not be monitored with a personnel dosimeter. The personnel dosimeter is worn at the level of the chest or waist during radiography. If an individual is involved in fluoroscopic procedures, the dose under the apron is known to be a small fraction of the dose to the head and neck. The dosimeter should be positioned on the collar outside the protective apron, or outside the thyroid collar, during fluoroscopy. The personnel dosimeter should not be worn on the sleeve. The collar reading greatly overestimates the dose to the total body. To account for the protective effect of the apron and determine an effective whole body dose, called the effective dose equivalent, the collar reading is multiplied by a factor of 0.3. A measured value of 3 msv, 300 mg, for the collar dosimeter is equivalent to a whole body dose of 0.9 msv, 90 mg. The annual dose limit of 50 msv, 5000 mg, applies to the effective dose equivalent. When not in use, personnel monitoring devices should remain at the place of employment in a low background area, such as a locker or office. Personnel monitoring devices should not be stored in areas of X-ray use. ALARA. In recent years, radiation protection measures have been devised according to the principle of ALARA. Radiation exposure should be maintained at the lowest practicable level and very much below the dose limits. All technologists should practice the ALARA principle so that patients and other healthcare professionals do not receive unnecessary radiation. Following is a summary of 4 important ways that ALARA can be achieved. 1. Always wear a personnel monitoring device. Although the device does not reduce the dose to the wearer, exposure history has an important impact on protection practices. Radiologic technologists should ensure individuals present during X-ray operation wear personnel monitors as appropriate. 2 mechanical holding devices, for example, compression bands, sponges, sandbags, and 2-inch wide tape, are effective tools for the immobilization of patients and should be used if the procedure permits. Only as a last resort should someone hold the patient. The following criteria are applicable for the selection of someone to hold during a radiographic procedure. No individual shall be regularly used to hold patients. An individual who is pregnant shall not hold patients. An individual younger than 18 years of age shall not hold patients. Whenever possible, an individual occupationally exposed to radiation shall not hold patients during exposures. A parent or family member should be used to hold the patient if necessary. A hospital employee who is not occupationally exposed may be used to hold the patient if necessary. If an individual holds the patient, he or she is provided with a protective apron and gloves. The individual is positioned so that no part of his or her body except hands and arms is exposed by the primary beam. Only individuals required for the radiographic procedure should be in the room during exposure. All persons in the room except the patient are provided protective devices. 3. Close collimation, filtration of the primary beam, optimum KV technique, high-speed IRs, and avoidance of repeat projections reduce the dose to the patient. 4. Practice the 3 cardinal principles of radiation protection: time, distance, and shielding. The technologist should minimize the time in the radiation field, stand as far away from the source as possible, and use shielding, protective devices or control booth barrier. For individuals not shielded by protective barrier during X-ray operation, the radiologic technologist should ensure that these persons wear lead aprons and gloves as appropriate. Exposure to persons outside a shielded barrier is due primarily to scattered radiation from the patient. Therefore, a reduction in patient exposure results in decreased dose to workers in unshielded locations. Protection from scatter radiation is an important consideration during mobile C-arm fluoroscopy. In the absence of a radiologist during X-ray examination, the radiologic technologist generally has the highest level of training in radiation protection. The radiation safety officer designates the radiologic technologist to be responsible for good radiation safety practice. An essential component of a radiation safety program is that individuals present during X-ray operation wear protective lead aprons and personnel monitors as appropriate. However, for the radiologic technologist to function in this capacity, management must have a clearly defined policy, which is communicated directly to staff and ultimately enforced by management. Individuals who do not follow radiation safety policy of the institution should be subject to disciplinary action. Pregnant technologists. Studies have shown that the fetus is sensitive to high doses of ionizing radiation, especially during the first 3 months of gestation. A small risk of harmful effects from low doses of radiation is assumed, but not proven, to exist. That is, any radiation dose, however small, is considered to increase probability of harm to the fetus. Effective, fair management of pregnant employees exposed to radiation requires the balancing of 3 factors: 1. The rights of the expectant mother to pursue her career without discrimination based on sex; 2. The protection of the fetus; and 3. The needs of the employer. Each healthcare organization should establish a realistic policy that addresses these 3 concerns by clearly articulating the expectations of the employer and the options available to the employee. A sample pregnancy policy for radiation workers has been published in the literature. The pregnant technologist should review the institutional policy and other professional references to determine expectations and the best practices to protect her unborn child. The recommended equivalent dose limits to the embryo fetus is 0.5 msv, 50 mg, during any 1 month and 5 msv, 500 mg, for the gestation period. To recognize the increased radiosensitivity of the fetus, the total fetal dose is restricted to a level that is much less than that allowed for the occupationally exposed mother. However, the expectant mother's exposure from other sources, such as medical procedures, is excluded from the fetus dose limit. The fetal dose limit can be applied only if the employer is informed of the pregnancy. The regulations define the declared pregnant woman as one who voluntarily informed her employer, in writing, of her pregnancy and the estimated date of conception. In recent years, radiation protection measures have been devised according to the principle of ALARA. Radiation exposure should be maintained at the lowest practicable level. Radiation protection practices do not change because the worker becomes pregnant. The measures that reduce the dose to the worker also reduce the dose to the fetus. The major ways to decrease the dose further are to restrict the type of tasks performed or to limit the number of times a particular task is performed. When an employee first discovers she is pregnant, it is desirable to conduct, on an individual basis, a review of her exposure history and work assignments. If a radiologic technologist has averaged 0.3 msv, 30 mRAM, per month for the last several months, a reasonable projection is that this individual, as well as her unborn child, will not receive more than 5 msv, 500 mRAM, during the period of gestation. This radiologic technologist could continue to work in her current capacity during her pregnancy. However, she should be encouraged to monitor her dosimeter readings and report any unusual reading to the radiation safety officer. Contrary to what is generally believed, fluoroscopy procedures do not result in high exposures to the fetus. For example, in fluoroscopy, attenuation by the lead apron and by overlying maternal tissues reduce the dose to the fetus. Personnel dosimeter readings totaling 500 mRAM at the collar correspond to a fetal dose of 7.5 mRAM. Consequently, radiologic technologists can continue their work assignments in fluoroscopy throughout pregnancy. For a declared pregnant radiation worker, the dose to the fetus is often monitored by placing a second dosimeter at waist level under the protective apron. This monitoring scheme generally produces readings below the detectable limit of the dosimeter and is useful only in demonstrating that the fetus received no measurable radiation exposure. The fetal badge must be clearly marked to distinguish the device worn under apron from that worn at the collar. Radiographic patient dose. For a particular radiographic examination, several different doses may be used to characterize patient dose. The most common descriptor is the exposure to the skin in the region where the X-rays enter the body, called the entrance skin exposure. Air Kerma is rapidly replacing exposure because it is easily converted to skin dose with the application of the backscatter factor. The backscatter factor takes into account the additional dose at the surface caused by scattering from tissue within the irradiated volume. As the X-rays directed toward the IR pass through the body, attenuation causes a dramatic reduction in dose. Exit dose is often a small percentage of the entrance dose. Specific organ dose varies depending on depth and radiation quality. If the organ is located outside the primary beam, dose is from scattered radiation only and is a small fraction of the in-beam dose. Entrance air Kerma and organ doses from common radiographic examinations are shown in an accompanying table. These values are representative of multiple facilities but vary according to technique factors, type of IR, field size, and patient size. The effective dose, ED, takes into account the respective dose to each organ and the cumulated relative risk from all organs that received dose. This dose metric essentially specifies a whole body dose that yields the same overall risk as incurred by the non-uniform dose distribution in the patient. Effective dose becomes a means to compare different imaging procedures with respect to potential for harm. Radiologic technologists subscribe to a code of ethics that includes responsibility to control the radiation dose to all patients under their care. This is a serious responsibility, and each of the following 7 ways of reducing patient exposure must be understood and put into practice as described in the next sections. 1. Minimum repeat radiographs. 2. Correct filtration. 3. Accurate collimation. 4. Specific area shielding, gonadal and female breast shielding. 5. Protection of the fetus. 6. Optimum imaging system speed. 7. Select projections and technique factors appropriate for the examination. Use high kV and low MAS techniques. Use PA rather than AP projections to reduce dose to anterior upper thoracic region, thyroid and female breasts. Use techniques consistent with system speed for digital radiography as confirmed by exposure indicator values. Minimum repeat radiographs. The first basic and most important method to prevent unnecessary exposure is to avoid repeat radiographs. A primary cause of repeat radiographs is poor communication between the technologist and the patient. Unclear and misunderstood breathing instructions are a common cause of motion, which requires a repeat radiograph. When the procedures are not explained clearly, the patient can have added anxiety and nervousness from fear of the unknown. Stress often increases the patient's mental confusion and hinders his or her ability to cooperate fully. To engage the patient, the technologist must take the time, even with heavy workloads, to explain carefully and fully the breathing instructions as well as the procedure in general in simple terms that the patient can understand. Patients must be forewarned of any movements or strange noises by equipment that may occur during the examination. Also, any burning sensation or other possible effects of ingestions should be explained to the patient. Carelessness in positioning and selection of erroneous technique factors are common causes of repeats and should be avoided. Correct and accurate positioning requires a thorough knowledge and understanding of anatomy, which enables the technologist to visualize the size, shape, and location of structures to be radiographed. This is the reason that every chapter in this text combines anatomy with positioning. Correct filtration. Filtration of the primary X-ray beam reduces exposure to the patient by preferentially absorbing low-energy unusable X-rays, which mainly expose the patient's skin and superficial tissue without contributing to image formation. The effect of filtration is a hardening of the X-ray beam, which shifts the beam to a higher effective energy resulting in increased penetrability. Filtration is described in two ways. First is inherent or built-in filtration from components of the X-ray tube itself. For most radiographic tubes, this is approximately 0.5 mm aluminum equivalent. Second, and more important to technologists, is added filtration, which is accomplished by placing a metal filter, aluminum or copper or combination of these, in the beam within the collimator housing. The amount of minimum total filtration as established by federal regulations depends on the operating kV range. The manufacturers of X-ray equipment are required to meet these standards. Minimum total filtration, inherent plus added, for diagnostic radiology, excluding mammography, is 2.5 mm of aluminum. For equipment operating at 70 kV or higher. Often, radiographic equipment has variable added filtration, which can be selected by the technologist. Added filtration becomes another component to adapt the acquisition parameters to the patient. Generally, as patient size increases, more added filtration provides skin dose sparing. The technique chart should specify the use of added filtration. The technologist has the responsibility to ensure that proper filtration is in place. The filtration of each X-ray tube should be checked annually and after major repair, X-ray tube or collimator replacement. Testing, in the form of measurement of the half-value layer, should be performed by qualified personnel, such as the medical physicist. Accurate collimation. Accurate collimation reduces patient exposure by limiting the size and shape of the X-ray field to the area of clinical interest. Careful and accurate collimation is emphasized and demonstrated throughout this textbook. The adjustable collimator is used routinely for general diagnostic radiography. The illuminated light field defines the X-ray field on accurately calibrated equipment and can be used effectively to determine the tissue area to be irradiated. Safety standards require light field and X-ray field concurrence within 2% of the selected SID. The concept of divergence of the X-ray beam must be considered for accurate collimation. Therefore, the illuminated field size as it appears on the skin surface appears smaller than the actual size of the anatomic area, which would be visualized on the IR. This is most evident on a projection such as lateral thoracic or lumbar spine, in which the distance from the skin surface to IR is considerable. In such cases, the light field, when collimated correctly to the area of interest, appears too small unless one considers the divergence of the X-ray beam. Collimation and tissue dose. Accurate and close collimation to the area of interest results in a dramatic drop-off in tissue dose as distance from the border of the collimated X-ray field is increased. For example, the dose 3 cm from the edge of the X-ray field is about 10% of that within the X-ray field. At a distance of 12 cm the reduction in dose is about 1% of that within the X-ray field. Positive beam limitation, PBL. All general-purpose X-ray equipment built between 1974 and 1993 in the United States required collimators with positive beam limitation, PBL, that automatically adjusts the useful X-ray beam to the film size. This requirement became optional after May 3, 1993, as a result of a change in U.S. Food and Drug Administration regulations. The PBL feature consists of sensors in the cassette holder that, when activated by placing a cassette in the Bucky tray, automatically signal the collimator to adjust the X-ray field to that film size. PBL can be deactivated or overwritten with a key, but this should be done only under special circumstances, in which collimation by manual control is needed. A red warning light is illuminated to indicate that PBL has been deactivated. The key cannot be removed while PBL is overwritten. Manual collimation. Even with automatic collimation, PBL, the operator can manually reduce the collimation field size. This adjustment should be made for every projection in which the IR is larger than the critical area to be radiographed. Accurate manual collimation also is required. For upper and lower limbs that are acquired tabletop, in which PBL is not engaged. Throughout the positioning pages in this textbook, collimation guidelines are provided to maximize patient protection through careful and accurate collimation. The practice of close collimation to only the area of interest reduces patient dose in two ways. First, the volume of tissue directly irradiated is diminished, and second, the amount of accompanying scattered radiation is decreased. Scatter radiation produced by additional tissue in the X-ray field from improper collimation or lack of shielding not only adds unnecessary patient dose but also degrades image quality through the fogging effect of scatter radiation. This is especially true in high-volume tissue imaging such as abdomen and chest. The practice of visible collimation on all four sides of a radiograph reduces patient exposure, improves image quality, and acts as a method to ensure that appropriate collimation did occur. If no collimation border is visible on the radiograph, evidence does not exist that the primary beam was restricted to the area of clinical interest. An added benefit of showing the extent of collimation on all four sides is the ability to check the final radiograph for correct central ray location. As described previously, this is done by imagining a large X extending from the four corners of the collimation field, the center of which is the CR location. Collimation rule. A general rule followed throughout this text indicates that collimation should limit the X-ray field to only the area of interest, and collimation borders should be visible on the IR on all four sides if the IR size is large enough to allow four-sided collimation without cutting off essential anatomy. Specific area shielding. Specific area shielding is essential when radiosensitive organs, such as the thyroid gland, breasts, and gonads, are in or near the useful beam and the use of such shielding does not interfere with the objectives of the examination. The most common and most important area shielding is gonadal shielding, which significantly lowers the dose to the reproductive organs. Gonadal shields, if placed correctly, reduce the gonadal dose by 50% to 90% if the gonads are in the primary X-ray field. Consider the following two examples. For a male, the AP unshielded hip delivers an ED of 0.43 msv, 43 mg. This is primarily due to the dose to the testes, which can be greatly decreased to 0.07 msv, 7 mg, with gonadal shielding. For a female, the apithoracic spine without breast shields produces an ED of 0.63 msv, 63 mg. This is primarily caused by dose to the breast, which can be reduced by breast shielding or collimation. ED is decreased to 0.35 msv or 35 mg. The two general types of specific area shielding are shadow shields and contact shields. Shadow shields, as the name implies, shadow shields, which are attached to the collimator, are placed between the X-ray tube and the patient and cast a shadow on the patient when the collimator light is turned on. The position of the shadow shield is adjusted to define the shielded area. One such type of shadow shield is affixed to the collimator exit surface with Velcro. Another type of shadow shield is mounted with magnets directly to the bottom of the collimator. These shields may be combined with clear lead compensating filters to provide more uniform exposure for body parts that vary in thickness or density, such as for a thoracic and lumbar spine scoliosis radiograph. Contact shields. Flat gonadal contact shields are used most commonly for patients in recumbent positions. Vinyl-covered lead shields are placed over the gonadal area to attenuate scatter or leakage radiation or both. These shields usually are made from the same lead-impregnated vinyl materials that compose lead aprons. Gonadal contact shields, 1 mm lead equivalent, absorb 95% to 99% of primary rays in the 50 to 100 kV range. Examples of these include small vinyl-covered lead material cut into various shapes to be placed directly over the reproductive organs. Male gonadal shields should be placed distally to the symphysis pubis, covering the area of the testes and scrotum. The upper margin of the shield should be at the symphysis pubis. These shields are tapered slightly at the top and are wider at the bottom to cover the testes and scrotum without obscuring pelvic and hip structures. Smaller sizes should be used for smaller males or children. Female gonadal shielding is placed to cover the area of the ovaries, uterine tubes, and uterus but may be more difficult to achieve. A general guideline for women is to shield an area 4 to 5 inches, 11 to 13 centimeters, proximal or superior to the symphysis pubis extent. ing 3 to 312 inches, 8 to 9 centimeters, each way from the pelvic midline. The lower border of the shield should be at or slightly above the symphysis pubis, with the upper border extending just above the level of the anterior superior iliac spines, ASIS. Various shaped female ovarian shields may be used, but they should be wider in the upper region to cover the area of the ovaries and narrower toward the bottom to offer less obstruction of pelvic or hip structures. The shielded area should be proportionally smaller. On children, for example, a 1-year-old girl would require a shield that is only about 2 to 3 inches, 6 to 7 centimeters, wide and 2 inches, 5 centimeters, high, placed directly superior to the symphysis pubis. Summary of rules for specific area shielding. Proper specific area shielding is a challenge for each technologist because its use requires additional time and equipment. However, the importance of protecting radiosensitive organs and the gonads from unnecessary radiation should be sufficient motivation to encourage consistent practice of the following 3 rules for gonadal shielding. 1. Gonadal shielding should be considered for all patients. A common policy of many imaging facilities directs the use of specific area shielding for all children and adults of reproductive age. However, the best practice is to shield the radiosensitive tissues outside the anatomy of interest for all patients. 2. Placement of gonadal shielding is necessary when the organ of concern lays within or near 2 inches, or 5 centimeters, the primary beam, unless such shielding obscures essential diagnostic information. 3. Accurate beam collimation and careful positioning is essential. Specific area shielding is an important additional protective measure but no substitute for accurate collimation. Pregnant patient. All women of childbearing age should be screened for possibility of pregnancy before an X-ray examination. This concern is particularly critical during the first 2 months of pregnancy, when the fetus is most sensitive to radiation and the mother may not yet be aware of the pregnancy. Posters or signs should be prominently displayed in examination rooms and waiting room areas, reminding the patient to inform the technologist of any known or potential pregnancy. If the patient indicates that she is pregnant or may be pregnant, the technologist should consult the radiologist before proceeding with the examination. If the mother's health is at risk and clear indications for an imaging study exist, the examination should not be denied or delayed because of the pregnancy. Radiation protection practices already described, especially careful collimation, should be used. For examinations of body parts above the diaphragm or below the hips, the scattered dose to the fetus is very low, and the examination may proceed normally. For examinations in which the fetus is in the direct beam and the estimated fetal dose is less than 10 mgy, 1 rad, the radiation dose should be kept as low as possible, consistent with obtaining the desired diagnostic information. Shielding of the abdomen and pelvis with a lead apron should be considered. Limiting the number of views should be considered. For examinations in which the fetus is in the direct beam and the estimated fetal dose is greater than 10 mgy, 1 rad, the radiologist and referring physician should discuss other options such as sonography and MRI that can provide the needed information. If the X-ray imaging procedure is deemed appropriate, the patient should be informed of the risks and benefits of the procedure. The clinician responsible for the care of the patient should document in the medical record that the test is indicated for the management of the patient. In the past, the 10-day, or LMP rule, last menstrual period, was applied to prevent exposure to the embryo fetus early in pregnancy, when the pregnancy is not known. This rule stated that all radiologic examinations involving the pelvis and lower abdomen should be scheduled during the first 10 days following the onset of menstruation because conception will not have occurred during this period. Currently, this rule is considered obsolete because the potential harm associated with canceling essential X-ray procedures may greatly exceed the risk of the fetal radiation dose. The following examinations deliver a dose of less than 10 mgy, 1 rad, to the embryo fetus. Extremities: chest, skull, thoracic spine, head CT. The following examinations have the potential to deliver a dose of more than 10 mgy, 1 rad, to the fetus and embryo. Lumbar spine series. Fluoroscopic procedures: abdomen, abdomen or pelvis with 3 or more views. Scoliosis, full series. CT abdomen, CT pelvis. Optimum speed. As a general guideline, the highest speed film screen combination that results in diagnostically acceptable radiographs is desirable to manage patient dose. The presence of the screen does result in some loss of spatial resolution and becomes more pronounced as the speed is increased. The radiologist must balance the reduction in patient exposure with the potential loss of detail in the resultant image. A common practice is to select a slow 100 speed, detail, screen with tabletop procedures, such as upper and lower limbs, when a grid is not used and spatial detail is important. A 400 speed screen is commonly preferred for larger body parts when grids and higher exposure techniques are required. For other applications, a 200 speed screen may be preferred. Departmental protocol generally indicates the film screen combination for each procedure. This is not a decision that is usually made by individual technologists. Digital imaging systems have essentially replaced film screen for most radiographic applications. These digital receptors are more sensitive than film screen and have the potential to reduce patient dose greatly. In addition, their wide dynamic range results in fewer repeated films. Automatic exposure control, AEC, for digital systems is usually set at an exposure indicator level that produces images with an acceptable level of noise. However, the technologist may adjust the AEC density control to change the effective system. Speed. The wide dynamic range of digital receptors enables this variation in dose, while still producing a quality image, although noise becomes more pronounced as the dose is reduced. Because the FPD-TFT is often integrated into the radiographic unit, the variable speed option is readily available to customize the speed for each imaging protocol. Minimize patient dose by selecting projections and exposure factors with least patient dose. The seventh and final method to reduce patient dose requires an understanding of the factors that affect patient dose. For example, technologists should know that patient dose is decreased during AEC when the kV is increased. For manual technique, an increase in kV with no change in MAS results in higher dose to the patient. The goal is to use the combination of technique factors that will provide acceptable image quality and minimize patient dose. There is a substantial difference in dose to the thyroid and female breasts for the AP projection compared with the PA projection for the head, neck, and upper thorax region. The ovarian dose can be reduced for certain projections, such as a female hip, if a specific area shield is correctly placed. An axiolateral or infero-superior lateral hip projection compared with a lateral hip projection delivers higher dose to the testes. Technologists must adhere to ethical and safe practice when using digital technology. The wide dynamic range of digital imaging enables an acceptable image to be obtained with a broad range of exposure factors. During the evaluation of the quality of an image, the technologist must ensure that the exposure indicator is within the recommended range. Any attempt to process an image with a different algorithm to correct overexposure is unacceptable. It is vital that patient dose be minimized at the outset and that the ALARA principle is upheld. To maintain dose at a reasonable, consistent dose level, the following practices are recommended. 1. Use protocol-specific kV and MOS values for all procedures. If no exposure protocol exists, consult with the lead technologist, physicist, or manufacturer to establish one. Increasing kV by 5 to 10 and decreasing MAS by the equivalent ratio can produce a quality image with digital imaging systems while reducing patient dose. 2. Monitor dose by reviewing all images to ensure that radiographs were obtained with the established exposure indicator. 3. If the exposure indicator for a given procedure is outside of the acceptable range, review all factors, including kV and MAS, to determine the cause of this disparity. Processing of digital images can be adversely affected if the exposure indicator deviates from the manufacturer's acceptable values. Fluoroscopic patient dose. Because fluoroscopy can potentially deliver high patient dose, federal standards have set a limit of 10 Rmin for the tabletop exposure rate, which corresponds to an air Kerma rate of 88 mgy per minute in high-level fluoroscopy, HLF, mode. The exposure rate at tabletop cannot exceed 20 rads per minute or an air Kerma rate of 176 mgy per minute. For C-arm fluoroscopic units, the point of measurement is specified as 30 cm from the IR-HLF mode should be reserved for instances where the lack of penetration creates a poor image, large patients. There is no exposure rate limit when the image is recorded, as in digital cine and serial digital spot filming. With most modern equipment, the average tabletop fluoroscopy exposure rate is 1 to 3 rads per minute, air Kerma rate of 8.8 to 26 mgy per minute. Use of magnification mode increases the instantaneous exposure rate but decreases the volume of tissue irradiated. Typical patient doses during gastrointestinal fluoroscopy procedures are shown in the accompanying table, which includes approximate entrance air Kerma during fluoroscopy and spot filming. Fluoroscopic procedures generally involve much higher patient dose than conventional overhead tube radiographic examinations because of the need to penetrate the contrast media and the time required to conduct the study. The volume of tissue exposed during fluoroscopy and spot filming is fairly small. Dose area product, DAP. The FDA requires fluoroscopic units manufactured after 2006 to provide a means for the operator to monitor radiation output. Two types of readout, dose area product, DAP, and cumulative total dose, have been developed for this purpose. The total dose in mgy represents the dose to a point at specific distance from the focal spot. DAP is a quantity that indicates a combination of dose and the amount of tissue irradiated. It is calculated as the product of the air Kerma and the cross-sectional area of the beam, expressed in units of micrograys per square meter or centigrays per square centimeter or rads per square centimeter. Skin injury. The FDA has issued a public health advisory regarding radiation-induced skin injuries from fluoroscopic procedures. These injuries are usually delayed so that the physician cannot discern damage by observing the patient immediately after the procedure. The radiation dose required to cause skin injury is typically 3 grays, 300 rads, for temporary epilation, onset 2 to 3 weeks after exposure, 6 grays, 600 rads, for main erythema, onset 10 to 14 days after exposure, and 15 to 20 grays, 1,500 to 2,000 rads, for moist desquamation, onset several weeks after exposure. The procedures of concern are primarily interventional procedures during which fluoroscopy is used to guide instruments. Risk of skin injury is associated with prolonged fluoroscopy time and multiple digital cine acquisitions to a single skin site. At the maximum rate of 10 rads per minute, the fluoroscopy time must exceed 30 minutes to cause skin injury. However, during angiography, the patient may be positioned close to the X-ray tube where the fluoroscopy exposure rate can exceed 10 rads per minute. Digital recording may employ very high exposure rates. If digital recording is performed, the fluoroscopy time to cause skin injury is greatly reduced. Monitoring of total dose or DAP during interventional procedures is essential for the prevention of skin injury. Dose reduction techniques in fluoroscopy. Most operators are trained to activate the X-ray beam for a few seconds at a time, long enough to view the current catheter position or the bolus of contrast agent. Total fluoroscopic times can be reduced dramatically with intermittent fluoroscopy. This technique is particularly effective when combined with last image hold. Many modern fluoroscopy systems have the capability to retain the last fluoroscopic image on the monitor after X-ray exposure is terminated. This allows the physician to study the most recent acquisition and plan the next task without radiation exposure to the patient. During pulsed fluoroscopy, the X-ray beam is emitted as a series of short pulses rather than continuously. For conventional fluoroscopy, the image is acquired and displayed at a constant 30 frames per second. Pulsed fluoroscopy at 15 frames per second compared with the usual 30 frames per second demonstrates substantial dose reduction, factor of 2. However, manufacturers may increase the radiation level per frame to achieve a more pleasing visual appearance, less noise, and the dose reduction may be only 25%. Mobile C-arm fluoroscopic units make pulsed fluoroscopy available at low frame rates, for example, 8 frames per second. Low frame rates adversely affect the ability to display rapidly moving structures. Large field size increases the amount of scatter radiation produced. Additional scatter radiation enters the receptor and degrades the resulting video image. Collimation to the area of interest improves image quality but also reduces the total volume of tissue irradiated by excluding tissue with little diagnostic value. The design of the fluoroscopy system may incorporate variable or operator-selectable filtration. Substantial reductions in skin dose can be achieved by inserting appropriate metal filters, aluminum or copper, into the X-ray beam at the collimator. Filtration reduces skin dose by preferentially removing low-energy X-rays, which generally do not penetrate the patient to contribute to the image. The presence of a grid improves contrast by absorbing scattered X-rays. However, the dose to the patient is increased by a factor of 2 or more. For pediatric cases, the removal of the grid reduces the dose with little degradation of image quality. Grids should be used with discretion when fluoroscopic studies are performed on children. These systems should have the capability for easy removal and reintroduction of the grid. In most interventional fluoroscopic procedures, most of the fluoroscopic time the X-ray beam is directed toward a particular anatomic region. Some reduction in maximum skin dose can be achieved by periodically rotating the fluoroscopic X-ray tube to image the anatomy of interest from a different direction. This method tends to spread the entry dose over a broader area, reducing the maximum skin dose. Scattered radiation. During routine fluoroscopy of the gastrointestinal tract, personnel are exposed to radiation scattered by the patient and other structures in the X-ray beam. Scattered radiation levels depend on entrance exposure rate, field size, beam quality, and patient thickness but decrease rapidly with distance from the patient. The IR, tower lead drapes, Bucky slot shield, X-ray table, footrest, if present, and radiologist all provide a source of shielding for the technologist. The Bucky slot shield covers the gap under the tabletop that allows the Bucky to move along the length of the table for radiography. The area behind the radiologist and away from the table has the lowest scattered radiation level, less than milliroentgens per hour. When the receptor is lowered as close as possible to the patient, much of the scatter to the worker's eyes and neck is eliminated. The vertical and lateral extents of the scattered radiation field contract dramatically as the distance between patient and receptor is reduced. Radiation protection practices during fluoroscopy. Even with correct shielding in place and the IR as close to the patient as possible, scatter radiation is still present during fluoroscopy. Radiation levels are highest in the region close to the table on each side of the radiologist. The presence of tower drapes greatly reduces the dose to the radiologist. Technologists and others in the room can decrease their dose by not standing close to the table on either side of the radiologist. All individuals participating in fluoroscopic procedures must wear a protective apron. A 0.5 mm lead equivalent apron, which reduces the exposure by a factor 50 over the diagnostic X-ray energy range, is recommended. Typical doses under the apron are below the threshold of detectability for personnel monitors. Dosimeters placed under the apron show readings only for individuals approaching the dose limit, which are typically less than 20 mg. Aprons of multiple element composition with a 0.5 mm lead equivalence between 80 and 110 kV offer the advantage of reduced weight. However, some manufacturers of light aprons achieve a weight reduction by the removal of lead vinyl layers, sacrificing some protection. Technologists should be cautious about using aprons with large cutouts around the arms and low necklines. These allow greater exposure to the thyroid and breasts. Although some protective aprons have a thyroid shield built into them, most do not. A separate thyroid shield can be worn with the apron to protect the neck region. Although a thyroid shield is not required for an individual participating in fluoroscopic procedures, a thyroid shield should be available, provided by the healthcare facility, for use at the option of the radiation worker. Wearing the thyroid shield is consistent with the ALARA principle, but the overall reduction in effective dose provided this device is small. For an individual approaching a significant fraction of the dose limit, the thyroid shield is recommended. The threshold for a vision-impairing cataract is at least 5.5 grays, 550 rads, accumulated in a period of more than 3 months. This threshold value exceeds the radiation dose that can be reasonably accumulated by the lens of the eye during a lifetime of occupational exposure under normal working conditions if recommended practices are followed. Therefore, with the possible exception of very busy interventionalists, eyeglasses with lenses containing lead offer no practical radiation protection value. Radiation attenuating surgical gloves offer minimal protection of the operator's hands, provide a false sense of protection, and are not recommended. The instantaneous dose from scatter radiation is reduced when the hands covered with one layer of glove material are located near the radiation field. However, the total time near the radiation field depends on the speed at which the procedure is performed as well as the distance from the imaged anatomy when the X-ray beam is activated. The increased thickness of these gloves reduces dexterity and can increase procedure time. The automatic exposure control system in fluoroscopy increases the radiation output to penetrate the glove when the hand is present in the beam. This can be confirmed by noting that anatomy is seen even though the glove is present. The dose to the hand is comparable to the dose when the radiation attenuating glove is not present. The cost of radiation attenuating surgical gloves and the minimal dose reduction do not justify the use of these devices according to the ALARA principle. Image Wisely. Image Wisely is an awareness program, developed jointly by the American College of Radiology, Radiological Society of North America, American Association of Physicists in Medicine, and American Society of Radiologic Technologists, to promote radiation safety in adult medical imaging. The goal is to eliminate unnecessary radiation associated with adult imaging by avoiding non-medically indicated imaging procedures, by conducting the most appropriate imaging procedure, and by using the lowest optimal dose in all imaging practices. Printed and electronic educational resources have been developed for radiologists, medical physicists, radiologic technologists, referring physicians, patients, and the general public. Topics include dose reduction techniques, appropriateness of imaging procedures, and risks. The information is directed at each respective target audience. A similar campaign, called Image Gently, is designed to minimize the radiation exposure in children, whose long life expectancy and increased radiosensitivity contribute to higher lifetime cancer risk.